Well, good evening. Thank you all for joining us. This is the webinar on new technology for occipital cervical fixation, presented to you by the Cervical Spine Research Society. I'm very pleased to co-moderate this with Dr. John Heller. A couple reminders. We do have the 52nd annual meeting of the CSRS coming up this December in Chicago. Abstracts are currently being accepted for another few weeks until April 24th. So we encourage everyone, if you have any research to submit, we would love to see it at the 52nd annual meeting. We also want to remind people that the Clinical Spine Surgery Journal is the official journal of the Cervical Spine Research Society. We'd encourage you to submit any papers focused on cervical spine to the Cervical Spine Surgery for possible inclusion in the upcoming issues. We're also, with the CSRS, becoming involved with social media, so we encourage you to follow us on the various formats, whether it's in LinkedIn, Instagram, X, or Facebook, and those are all the various identifications of CSRS on those societies. So please give us a follow so we can keep you up to date on any other upcoming events with CSRS. And then, as I mentioned, CSRS has a YouTube channel. This is a repository of presentations put on either at CSRS, the instructional course, or webinars like this. There's a growing amount of information there, so please give it a look and subscribe to the CSRS YouTube channel. So tonight, this is just our agenda for the evening. So Dr. Heller and I will lead off. Then we'll have Dr. Heller will do a review on anatomy. I will talk about how I do it for occipital cervical using both freehand and Fluoro-assisted. And then we're really pleased to have Ilyas Aleem from University of Michigan to talk about how he does it with navigation assistance. And we're especially proud to have Dr. Nick Theodore from Johns Hopkins, one of the fathers of robotic spine surgery, give us his take on how he does it using robot assistance. And then we'll finish up with some case presentations. We have one from Dr. Heller, and if time permits, I have one as well. And we'll all the panelists will be there for a live discussion.
All right, so let's start with the first case presentation. I'll throw it out to the group for conversation. Here's a 76-year-old female with moderate to severe rheumatoid arthritis. She's been on DMARDs for about a decade. She's had progression of her disease with involvement of her extremities over the last 4 or 5 years. Her complaints are chronic neck pain with progressively worsening gait, as well as increasing bilateral upper extremity weakness and pain, left more so than right. Also some worsening dysphagia with solids and liquids. 5'2", 90 pounds. She's essentially wheelchair bound. She has fairly gnarled hands with severe ulnar deviation, wrists consistent with her RA. She has positive Hoffman sign on the left. No other pathologic reflexes. Next, there's a table of her motor strength. You can see she has some global weakness in her lower extremities, but quite advanced weakness throughout the upper extremities, distal more than proximal. Here's her lateral cervical x-ray. Note the hard to find bone. And here's a close-up of her upper cervical spine, which brings us to the topic of discussion today. Here's her MRI and the CAT scan to match. And here are the two side by side. So why don't we pause there, back up a slide, and kind of turn it over to the discussants.
So, I mean, a great case, John. I think just saying right out of the gate, thankfully, we're seeing less and less in this with the biologics. I mean, this used to be, you know, when I was trained in Phoenix in the early 90s, we saw this was 25 cases a week like this. And this has been going down, you know, because of medications. I mean, my first comment obviously is at 90 pounds and 5'2", when we really have to just be very careful about, you know, is this lady somebody's going to be able to get through surgery? And, you know, the frailty and resilience ability to get through this is just something to consider. But I think, from an operative perspective, and in my mind, what can we get better than this? So is there an opportunity with traction to get her into a better alignment? I think would be the place to start. Because if you can, that makes things a lot easier for fixation. Neil, I don't know what you think.
No, I absolutely agree. I mean, trying to get her reduced before surgery would be ideal. It's also her bone quality looks quite poor, and that certainly would have to figure into any ultimate construct. So, John, if you mentioned overall fragility, but frailty, but does she have reasonable bone health, or?
Well, she has reduced bone quality that would go hand in hand for her generation and her disease and the treatments along the way. And in terms of frailty, yeah, she's not the healthiest person in the world, but she understands the deal. She understands how much her progression has cost her functionally, and is quite open-eyed about trying to do something to reverse her course.
And I agree with Nick. I think getting this reduced would be ideal. I mean, years ago, this is something I think there would be some consideration for doing an anterior approach to resect that, but I think that's really fallen by the wayside, just the morbidity of that. So here it's trying to get it reduced and then stabilizing her in that position.
That's sort of an important sort of nod to history, right? If we had Alan Crockard here on the panel, and this was well before we had any of the sort of modular fixation stuff that we now have today. Alan pioneered and perfected a transoral resection of the dens, followed by a posterior fusion, and that posterior fusion would have been using all those sort of old school techniques that I talked about in the beginning of my presentation. But he was a master at it, and it worked pretty darn well in his hands. Not too many mortals could repeat his success.
Unless they use navigation, might be
Right. So out of curiosity, just for the people listening in, and you say traction, be specific. How are you applying the traction? How much weight for how long? And how do you monitor the progress?
So,
Yeah.
I think Gardner-Wells tongs in the ICU monitor setting, and start off at maybe 10 pounds and then go from there with serial x-rays and see what we get over the course of 24 to 48 hours.
And I find the x-rays are often quite difficult. So just especially with the Gardner-Wells in a bed doing a cross bed x-ray, oftentimes they're getting multiple CTs to really see what you've done, to see if you've gotten any reduction.
Okay.
So
what would you?
I would give this a few days. I mean, most of the patients aren't going to tolerate too long a period of traction, and this is one that if I can't get reduction in a few days, I've gone to trying to getting these reduced in the OR, and I think using the hinge rods are very effective for that, where you can apply traction just below the hinge, essentially lift the head up off the spinal fixation. So there's a couple tricks we can use, I think.
And her bone's not great. The other, obviously, that you can distract if you can get a good subaxial fixation and cranial fixation. You can distract off the rod as well.
Yeah.
And that's powerful. I think it's gentler and probably safer at the beginning, just to start off with, see what you can get. But I agree with you. And then again, you're taking an elderly patient with significant debility and putting them in the ICU for a few days. It's again, the quicker you get this done, the better for her.
Right, but I think, Nick, as you alluded to earlier, the ultimate spinal cord monitoring is the awake, alert patient that you can serially examine over a few days, and as you said, also follow the X-rays. And for a starting weight, most people would sort of say you want to think about 15 pounds just being the weight of the head, and in a neutral supine position, you then have to at least counteract the tone of the cervical muscles and add enough force to start trying to stretch the ligaments. So, 15 to 20 pounds is probably a starting point, and you kind of go up from there depending on how things go.
I only dialed that down, John, because she only weighs 90 pounds. I don't want to pull her out of bed. So
We do have a couple questions posed by the audience. John, there's Vijay Loya wanted to know if there was any takers for anterior transoral first. I think we addressed that. I may have thought about that the very first few years of my practice, 25 years ago. That would not cross my mind as a approach now.
Yeah, most people probably would reserve the transoral for a circumstance where they were only partially effective or ineffective in the circumstance that we're talking about, right?
Right.
Would you guys agree with that?
yeah, fixed deformity where we just can't relieve the compression in the other way.
Yeah, I mean, I think there's a lot you can gain with the preoperative traction and potentially avoid the anterior approach, especially in a patient like this, with probably not a lot of reserve to the morbidity of the anterior approach and just losing more weight and all that kind of stuff. So
Okay, so let's go to the next slide. So this was sort of anticipating people's different potential approaches to doing this, and we sort of touched on all these points already about the different potential surgical options, preoperative versus intraoperative reduction, that sort of thing. Next slide. And next slide. So here she is at the initiation of, and then a lateral x-ray after 4 days of tongue traction.
So significantly better.
And now that we got that, you can see the progression of her lifted her head off of her neck. The question, of course, then is how to make it stick. So we heard 3 different ways of doing it. We're doing kind of old school fluoro, near-term nav, and then super sexy robotic.
Yeah, I'll follow in the middle, even as an advocate of the robot. I think the reason that I really think utilizing image guidance is so important is that it does give you the opportunity to exploit absolutely the best corridor possible. I mean, Neill is phenomenal with X-ray. There's no doubt about it. But if you can't see the bone, you can't put a screw in safely. So having a 3-dimensional CT scan at the ready, it really is, I think for me at least, an absolute necessity for something like this.
And I would agree with that. I mean, it depends on what you're trying to fixate. So most times when I'm doing occipital cervical, as part of the construct, a C2 par screw is fine. Occasionally a laminar screw. But for cases like this, you want the most robust fixation as possible. I'd want to put a C2 pedicle screw in, and for that, I would want navigation. So I wouldn't trust the anatomy and trying to put a C2 pedicle screw in just with thoracoscopy.
I think it would be. Go ahead.
No, I was saying I would advocate for navigation on this case.
Yeah, and I think here it would be important to hold the position. So, I'd even think about potentially like a halo preoperatively, holding the reduction in place, and then also being able to assess the head position of the patient prior to an occipital cervical fusion. And then that when you're positioning the OR, you've already got, you're going to have a good sense of where the head should be.
Yes, Ilyas, that's a good practical point. There are halo devices that actually attach directly to the Mayfield superstructure. So if you were putting somebody like this in traction, for instance, if you use a Bremer halo ring instead of Gardner-Wells tongs, you can get the traction done just the way you want. If you wanted to sort of lock them up in the halo vest for movement positioning, you could do that. And then when they're on the OR table, it attaches directly to the Mayfield. So you have the ability to intraoperatively sort of manipulate the head-trunk relationship, which can be very helpful in certain circumstances. But for those listening in who might not be terribly familiar with Halo products, or the fact that that option exists to attach it to a Mayfield, it's worth jotting down the note.
Yeah, absolutely. I mean, that's one that we use for extremely unstable spines, like in those ankylosing spondylitic fractures or things like that as well. Just kind of lock the position. It makes the flip a lot less stressful.
Okay, why don't we go to the next slide? So here's the post-op CT showing, the now fixed relationship after the occipital cervical instrumentation and bone grafting. The plain X-ray that goes with it.
Is that is that bone graft? Is that iliac crest, John? It looks like, or
Yeah, that's iliac crest autograft.
so the other, yeah, just one other little technical note too. Rib, it's fantastic. Sometimes in this older age group, it's difficult. The ribs aren't as robust, but in a younger person, the curvature of the rib fits perfectly in the occipital cervical region there, and it's very easily harvested right below the scapula. And if from a structural autograft standpoint, I find that if you're going to harvest autograft bone, I think that really is the best. I think it's less painful than the hip too.
Yeah, I think that's a sort of style point. I'm
So a
continuing
couple
to
technical
amazed
points,
how many
John.
people come to train with us who've scarcely ever seen an autograft harvested.
Yeah, that's becoming the case.
So a couple technical points, John. I think we'd already talked about doing some intraoperative traction as well. So if you're not satisfied with your reduction, you'd have to be careful here because of the bone health. But as both Nick and I had already talked, various ways of just applying traction onto the rod to help further reduce. One of the comments put in by the listeners by Andre Joachim raises a good point. Maybe not so much for this case, but for people of basilar invagination who still have reasonably strong bone, putting in progressively taller spacers into the C1-2 joint will also further help reduce C1 off of C2. I don't think it'd be that helpful for this lady given her bone quality, but for people who have reasonable bone health, that's also a very good trick of putting in anywhere 3, 4, 5, 6 millimeter height spacers in that C1-2 joint really helps lift C1 up off of C2 and help with this.
I actually touch on that in a couple of slides down.
Sorry.
No, it's a good point, because if you've reduced somebody like this, you've created a significant gap in the load-bearing column between the occipital condyles and the rest of the cervical spine. So if you do what was shown on this X-ray, you're relying exclusively on the purchase of the bone with the screws and the fatigue life of the rods. On the other hand, if you can create a load-sharing environment that transmits the load from the skull down onto the lower cervical spine, you greatly reduce the strain at the bone screw interface or in the implants themselves. So would you skip ahead on the slides kind of quickly, and you see, this was an example of a rheumatoid with kind of rotatory subluxation and scoliosis. Keep going. You had an asymmetric erosion of the lateral masses, and in traction, you end up creating this space. So on one side, I just used a transarticular screw. Next slide. And the other side to figure out what to do with that gap. There is nothing left of C1 to put a screw in, right? It's just a little wafer, and about the same thing of 2 on that side. So next slide. So here's the exposure after kind of identifying the C2 nerve root, and then you ligate it, as Neill mentioned. Keep going. Now you're actually looking into that gap that was the distracted C1-2 joint. And I think this gets to the point that the listener was talking about. I just shape a piece of allograft to the size that you need it, and go ahead. Next. You can slip it into that space, and I think do what we were talking about with the load bearing. This is a technique that was popularized by Goyle, the sort of the originator of the whole Goyle harms technique. He actually has sort of purpose-made titanium bits that he uses for this, but you know, the piece of allograft is infinitely shapeable. But I think it's a clever technique to be thought about, and may help in some tricky situations. And that was sort of the end result of that particular procedure. Okay. And one more, I think there's a healed post-op. Yeah, that's the healed surgery some 6 months later.
So that was a transarticular on one side and then a modified galley, it looks like.
Sort of a Rogers wiring, and then that sort of, I don't know, you call it a T-lift or a something, a pliff on the other side. Sort of a mix and match of techniques.
I think that's common when you're doing occipital cervical, of using different techniques.
Yeah. So still have a pretty good tendency. Neill, you want to show your case?
Yeah. There's a question from Andre Joaquim saying, I have a question about navigation for OC, C1, C2. Most of the cases, occipital C1-2 instrumentation is based on reliable anatomic landmarks for guiding screw insertion, such as C2 pedicle, for instance. With navigation, this very reliable landmarks are not used. I'm afraid that using navigation, some small slipping can lead to catastrophic complications. Once I don't have experience with that, I'd like some comment about the potential risk. And Ilyas, before I pass it on to you, I think that's one of the aspects of navigation, as the first generation bothered me, that you see residents or other people looking up at the screen at the path rather than necessarily down at the field where the tips of the instruments are. And I think that's one of the exciting things about some of the virtual reality glasses, where we're able to merge that together, where you're able to look at the field at the same time you're getting the advantages of the anatomy. Because I think that's one of the concerns I have with navigation, is where you're looking.
Yeah, and I think that's a great point. So you know, I think it's important to remember that when you start using navigation, it's not that you're ignoring the anatomy at all. You know, so I think you know, it's really sort of all eyes, all hands on deck. I mean, you're still doing it almost completely like you were doing it without navigation, but really using it as a tool or as a supplement to your standard technique. You know, I really like the technique of the fiducials, having those little fiducial screws kind of throughout, so you can kind of assess the accuracy throughout. But I think, yeah, I think that's an important point. And again, like, I think it could be very dangerous if you're just completely just looking at the screen and not. And I think that's a tendency for sure, because for the residents are trying to drill a track and they're trying to line up the screw with the track and all that kind of stuff. And then, you know, you'll see, like, you know, I'm looking down at the field, and then, you know, I'm glancing up and I'm really just looking down and getting a sense of where things are going. So, yeah, there definitely is a little bit of a learning curve, you know, I'm sure, as there is with robotics as well. But I think once that system is kind of defined, everybody kind of learns their own workflow, it could definitely be very safe.
Maybe Nick, your thoughts on that? I mean, how do you, with your, how do you?
Well, yeah, I think it's a different way of teaching things for sure. Listen, in these cases, we're doing them open, right? I mean, you know, people are doing that percutaneous cervical pedicle screws, you know, with the robot and whatnot. And you're going to always have, once that tip of the instrument is touching bone, you have feedback. So number one, if it's not lining up, whether you're doing it open or closed, you're wrong. You're off. You got to stop. So you always have the ability to take that probe, touch the midline of C2, touch the occiput, and if the tip is not showing you exactly where you are, then that's a problem. You need to stop. So it's a different way of teaching things for sure. The attention drift, to your point, 100% is there. People are looking, at the screen instead of the patient. I don't have a problem with that, but you have to understand too that you always have immediate feedback, and I think you need to understand you can always verify where you are. And just like Ilyas was talking about root guidance, it's like hitting the refresh button. What's your best way out of this? Making sure that the fidelity of your registration is good, but that's an ongoing process.
So I had another case example. This is probably the opposite age of the chronologic spectrum. This is a very young, active bodybuilder, 32-year-old male. He drove headfirst into a pool, shallow pool, while in Mexico, struck the top of his head, had neck pain, had some transient numbness. Initially evaluated before he got sent back to the United States, and he was neurologically intact, had a big laceration, and they closed. So Maria, if we can move to the next. So initial x-rays, and I apologize, the graininess of this lower one, maybe we go to the CT might show it, or the next x-ray might show it a little bit better. So you see it's a very disrupted C1, widely splayed. That right lateral mass is quite displaced. Could we go to the next? So you see on the reconstructions how far off that right lateral mass of C1 is. So it's completely disrupted the condyle C1 and the C1-2 joint on that side. On the left side of the anatomy, you can see the posterior arch has a fracture. On the right side, it's fairly distorted, but his overall alignment is good. Did not have acute spinal cord compression, just as a 3D reconstruction to show it. So the challenges here, very mobile fracture. And so how can we use these various tools to offer him fixation when it's going to be very difficult with essentially a floating lateral mass on one side? I mean, what could we use any tools to help address this?
On the left side, the occipital cervical junction appears to be intact, and C1 and C2 are a little bit distracted. So I think you're going to be safe instrumenting the left lateral mass of C1. The right lateral mass of C1, to your point, you've got to be very careful. The verse draped over there, and the fact is that I don't know, number one, what it's going to buy you, if anything. So I think you're probably going to bypass it on that side, and then it just goes straight to C2. I guess the interesting thing is if you go back one slide, you have a pretty significant disruption. I will go back one more to the OC1 on, I mean, you need to go up to the occiput. I don't think so that joint is destroyed on the one side. In the younger people, like really younger people in ages 3, 4, and 5 have had success with a unilateral dislocation on one side of getting a halo and having them sort of come back together. And I think at this age, the horse is out of the barn, and I don't think that's going to heal without occipital cervical fixation, but you could do a short construct from occiput to C2 probably.
Yeah, this is an interesting case, Neil. I think this is one where I would consider, this is a young guy, it seems like he's otherwise pretty active and all that. Upper cervical fusion would be pretty morbid for him. So I think this is one where I would consider almost stabilizing. So occiput to C2, skipping C1, and let the fracture heal. Even a post-op halo for a period of time. Let things just settle down, heal up, and then come back after a certain period of time and just remove the fixation. So really you're just using it as an internal brace kind of thing. Get some acute stability, hopefully avoiding the upper cervical fusion.
I've done that in some cases. I'm a little concerned on this one, just how laterally displaced that lateral mass is. So without it being in contact with the rest of C1, I don't know if that's ever going to heal. This is one I hadn't considered this at the time, and I'm not sure if I could have done it, but some of the C1 ring osteosynthesis surgeries that I've seen where if you're able to do a C1 lateral mass on both sides and then connect them with a rod, bringing them together, and then doing exactly that, putting in either internal or external stabilization and trying to let the C1 ring heal and see if you get away with it. This is, John, any thoughts on how you'd address it?
Yeah, I think one of the tricks in trying to manipulate a fragment like that is putting a K-wire in it. So you've now got kind of a little joystick or a lollipop to help you manipulate that lateral mass and hopefully get it reduced. I actually really like Ilyas's concept of what I would call a temporary internal halo. To do that, though, you need an intelligent patient who understands that there's a chance of some post-traumatic arthritis at OC1 or C12. But historically, we know from a number of series, if you treated these people in traction and then in a halo, even with a disrupted transverse ligament, they scab in well enough that they scarcely have an instability issue. The real question is, are they going to have pain? And if the patient is open to the N+1 operation to go remove the implants once the fracture's healed, or a second operation to bone graft and fuse them if the fracture doesn't heal, and I think it's a very reasonable option, especially in a young person. But you need somebody who can engage in that conversation and kind of gets it. And that's not every patient that comes along with an injury like this.
What metric, John, are you using to assess whether or not you're going to be able to take the hardware out?
I would do a CT scan at 6 months and look and see if the fracture's healed.
But what happens if the joints hasn't? I mean, the fracture, the C1 fracture, okay, it's probably, whether it heals or not, it might be irrelevant. What happens if there's still the space, if the occipital cervical joint's still disrupted as it is?
Well, we know the ligaments are torn, right? But the question is, as they heal and form scar, is it going to be functionally good enough? And once you take out the implants, if you follow them clinically and look at dynamic x-rays, the track record for these historically is they scab in spite of a ruptured transverse ligament and torn capsules. It's, in Alan Levine's series from Shock years ago, they rarely had to do C1-2 fusions for radiographic or symptomatic instability. So that's why I think Ilyas, it's a clever idea, but you have to have the right patient to pitch that.
Yeah, so I don't think I attached mine. I didn't think about trying to treat him conservatively or with a halo, letting it scab in. So I did what you all described, which was putting C1 fixation on the left side where there was an intact part of the C1, and did C2 screws and occipital plate. And he healed quite nicely. He did obviously lost a lot of range of motion, tolerated it fairly well. But I have a question sort of related to all these cases we were doing to both, to all three of you. And I think one of you brought it up, and Nick, you brought it up on your positioning about for occipital cervical, how critical it is for our intraoperative positioning of getting that head in the exact position. If they look up too high, they have difficulty walking. If they're looking down just a few degrees, they can't swallow very well. And I struggle with that. I mainly am doing that just visually looking at their head relative to their chest and really agonizing if they're in the right position. Do these other technologies, whether it's navigation or the navigation and planning with the robotics, does that help you position the head to the spine, or are there different measurements or metrics, or is it still just eyeballing that patient?
I think it's eyeballing. The one we just did one last week where I put a ruler from this guy's sort of chin, just put a ruler from the chin to the sternal notch and made that measurement and try to reproduce that in surgery and go left and right. There's probably a range of what's okay, and this, to my knowledge, there isn't anything, but it would be nice to be able to know that in the upright position when you talk to somebody and they're in a collar or a halo or whatever, and they're comfortable, that you're going to be able to recreate that. Because I think out of the first 120 cases, the one person I had to take back was a kid with, horrible congenital deformity of the neck with Morchios. And I fixed him into a perfectly neutral position and he couldn't breathe. I couldn't get the breathing tube out because his head was used to be an extension for his airway. So he comes off the table and everybody's like, oh my God, his head looks perfect. It's nice and straight. We couldn't get him extubated. I literally had to take him back to surgery and put him in extension and fuse him in extension because that's the only way that we could get him extubated. So understanding all those mechanics ahead of time are crucial. I think, nothing is worse than, waking up with this after this operation with not being able to swallow or.
Yeah, and I think if they have normal alignment to start with, which is actually fairly unusual for when you're doing OC fusions, but if they have normal alignment, then I will look at some of the feedback you can get from your lateral fluoro, like the clival C2 angle, and just making sure that I have them on the table the same position as their ideal films preoperatively. But when they have abnormal position to start with and you're trying to correct them, that's where I struggle a little bit. And going back to, I like using hinge rods, and for a variety of reasons. Doesn't matter what system you have, almost all of them have a hinge rod. Because there's one was actually a veterinarian who I did an OC fusion on, and I thought I had him in perfect position. And when I saw him post-op, his head was just slightly tucked, and I thought that was going to be okay. See him back in 3 weeks, and he's coming with back pain because he's now hyperlordosing his back so he can look forward. So rather than having to redo all the instrumentation, just open up a very small part of the incision under general anesthesia, of course, loosen up the hinge of the hinge rods, and just got a couple degrees of correction and locked them back down. So rather than having to take out all the hardware and rebend it, it made it a much easier fix. Had to happen once, but it's miserable when you have to take someone back because you've put their head in a slightly uncomfortable position.
Yeah, I mean, I really don't don't like uncertainty at all, and I think that I don't do, we're not doing like hundreds of these. So the few of these that we do, I do really like preoperative halos and get them in a position that they like. You can kind of tweak things, they can get used to it for a couple days. And it's kind of, not a guarantee, but it's kind of like, hey, this is what it's going to feel like, and then you do the surgery a lot less kind of stressed, at least for me. So yeah, I'm a fan of using that when I can. Obviously, you can't do that on everybody, such as this patient.
John, any other thoughts?
No, I think the whole idea about head and neck position and dysphagia is interesting. We never published it, but years ago, Tom Whiteside's, he happened onto this just from his years of experience. And so he found a member of our GI division who had a catheter that had different pressure sensors at different intervals down the catheter. So he convinced a bunch of us that it would be fun to have a halo put on, but instead of screws, it was just sort of a metal band around our heads, and put us in a halo vest and thread this pressure manometer catheter down our nasopharynx into our esophagus. And, in neutral position, they would swallow and take some measurements. And then he'd put us in that military chin tuck retroverted position and try to swallow. And then the sort of projected forward sniffing position. And if you're locked into a halo like that, it dramatically affects your ability to swallow or handle your secretions. It was a rather vivid illustration of what we could do wrong.
Well, I thought this was an amazing webinar. I really appreciate the working with John, and I really appreciate the input from Dr. Theodore from Johns Hopkins and Dr. Aleem from University of Michigan, looking at these new technologies. I think they are bringing extra tools to the field and making our surgeries better. So, John, unless you have anything different, I'd just like to thank everyone for participation and a wonderful webinar.
Yeah, thanks. It's like we had a good crowd, and hopefully everybody enjoyed it.
Yeah, thank you for putting together.
And Maria, thank you for cobbling all this together. Close it out. Have a good night, everyone.
Thanks.
Yeah, thank you, everybody.